Okay, hey guys, so I know that it's probably better or more helpful to do a recording on med-surg, but I feel like it's been a while since I've done one of these, so I'm just going to focus on what I've studied so far in mental health, and then I'll try to do one in med-surg as soon as possible. So I've got quite a lot of highlighting from mental health from last year. So I added new highlighting to that. So I'm just going to be going over some of the biggest points that stick out to me. So I'll try to go over some of the medications, and I'll try to make it fast, so it's not to use up any of our time. So let's just jump right into bipolar disorder. Bipolar disorder, according to the blueprint, is the one that has the most questions. I think that there were 13 questions on there. So I take the blueprint and do this, and then I find out which one has the most. So this one has the most. I think it's followed by this one, and then the other three are equal. So I like to focus on the one that has the most questions, and then I also like to circle the ones that are 4B, because 4B means that it's a medication question usually. Alright, so bipolar disorder, so bi means two, and polar means I just think of North Pole, South Pole. So, and bi, that means two, and polar, I guess, is kind of the opposite. So I think of two opposite things. And so mania is they're really, really happy, euphoric, everything is awesome, and then the depression is really, really down, and then they can be suicidal. And when they're maniac, when it's like a maniac, I think that might be where it comes from, but it's go, 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 and they never sleep, they never eat, they could suffer cardiac damages and all kinds of other stuff just because they never give themselves rest. That's what I've gotten from it. So let's see what my book says. So with bipolar 1, type 1, you can have a psychosis, you can have breaks with reality, that kind of thing. And then the depression's dangerous because they can be very, very low and get suicidal. So with bipolar disorder 1, they have to be maniac. They have to have mania for 1 week. And they're very energized, and they're not. They can be delusional and stuff, and not in their right frame of mind. So let's see. Yeah, loud, rapid speech, running, rhyming, clanging. It can be vulgar, dress really fancy, really a lot of makeup, be very kind of a seductive kind of deal with that. Play of ideas, that kind of deal. And then with the bipolar 2 disorder, they have hypomania and depression. So hypomania is they're not so energized or euphoric. They're like a step down from mania, but they still have it. And let's see, they don't have psychosis with hypomania. They need to have hypomania for but accompanied by excess activity and energy for at least 4 days. And then we have cyclothymia disorder. Cyclothymia, symptoms of hypomania alternate with the symptoms of mild to moderate depression for at least 2 years for adults and 1 year in children. And then they can also have rapid cycling, where they have 4 mood episodes in a 12-month period. And then with rapid cycling, one of the medications that is really good for that would be let's see. Oh, wait a minute. That would be lamotrigine. I don't know if I'm saying that right, but it's this medication right here. They say that that's really good for rapid cycling. I think it was. Oh, wait a minute. Wrong one. It's this one right here. It's the carbamazepine, whatever one. These are the anticonvulsant drugs. So the valproate, that one can help better than a lithium for very acute episodes of mania. But lithium is still, as far as I know, your number one choice. But these are just some of the anticonvulsants. You probably would do. It probably would help to go through and just look at the 3 different ones and when they would be used. speaking of lithium, you want to make sure that your lithium levels are, where we have it here. Your lithium levels. So your lithium levels, you want them always to be less than 1.5. If it's 1.5 or greater, then you can have lithium toxicity, and like some of the signs that you'd watch for would be like nausea and vomiting and like trembling. I mean, like a little bit of trembling, from what I remember from last year, is okay because that's expected. But if it's like you can actually like see them like trembling when they're like getting a cup and stuff, then that's probably like a sign that you'd want to do some further assessment and see if they have a lithium toxicity. And if they have lithium toxicity, you're going to have them hold a dose, and then you're going to talk to the provider or have them like just get further assessments, further testing, and that kind of sort of thing. Let's see here. So cyclothymia, also one thing about that, it's more for adolescents or early adulthood. And then when they have cyclothymia, they have a risk of it. There's a 15 to 50% risk that the individual will subsequently develop bipolar 1 or bipolar 2 disorder. So just like if they have cyclothymia, think that it's kind of like they have hypomania, and then they have like less severe depression. They're kind of in there for like 2 years for adults, 1 year in children, and then they could potentially go over to the completely bipolar type. And then with let's see here. So some of the neurotransmitters that might be involved would be norepinephrine, dopamine, and serotonin. And then they also say that if you have too few of these chemical messengers, then you can have depression because you're not having enough of like the feel good. Like dopamine's like a feel good, it's a pleasure thing. So if you have too few, then you can have depression. But if you have too much, then that may be causing that like wonderful, like pleasurable sensations when they're out of place, and it doesn't mean anything. So, and then like there's also like a genetic factor in there. So early diagnosis and proper treatment can help people avoid suicide attempts, alcohol or substance abuse, marital or work problems, and development of medical comorbidities. So with men and women can both get these. Both get this condition, but with men and women it's a little bit different. Men, they can have more like legal problems and violence. Women have more like things like with substance abuse. Might want to remember that. And then like the sooner they're assessed, it helps them to avoid like legal or marital problems, suicide attempts, substance abuse, hypomania. They can be like spending money, can't sleep. Yeah, and then like some of the things with mania is that they can be spending a lot of money. They can't sleep. They're giving their possessions away. They're not thinking. That front part of your brain, according to like CT imaging and stuff like that, it's not the prefrontal cortex can have like a little bit of a dysfunction when they do imaging there, and that's the one that makes all your judgments and decisions and stuff. And then they're always pushing limits, so you have to have like matter of fact. You don't engage in power struggles or anything like that, and you I think you would have try to split staff members against each other. So you're gonna want to have like frequent staff meetings, make sure that everyone's on the same page. They can also try to like seduce members of the opposite sex. So if you have an opportunity to have like a same sex maybe it's the wrong word. Like if you have a male bipolar patient, have a male nurse. You want a low stimulus environment. Don't want them watching TV or playing ball. Nothing to get them energized. More like relaxation. You want them in a private room. You want them not right next to the nurse's station, because there's a lot of like activity going on there, and then they're just going to grow and thrive on that and just get more hyped up. Bipolar can co-occur with substance abuse, anxiety disorders. You want to be firm when you're talking with them, but you don't want to like get in an argument with them or anything, or like like, just be matter of fact. Don't give them an opportunity to argue with you or anything like that, because then they'll take it and it'll be a power struggle, and that's going to be a mess, I guess. Let's see. So they can have grandiose delusions, hypersexuality. So some of the goals, you want to prevent injury, and then you want to have relapse prevention, and then you want to limit the severity and duration of future episodes. So safety is first, like physiological needs, safety kind of deal. You want them well hydrated, maintain normal cardiac status, get adequate sleep, keep patients safe is the #1 priority. So, like, if they're depressed, you're going to assess for suicide, and then if they're in their mania episode, then you're just going to want to, like, know, like, how they're doing, and like, if they're at risk of like cardiac problems, try to get them rest and nutrition as like soon as you can. It's harder and harder to get them back to the baseline each time that they relapse. So, and I think it's also the same with schizophrenia. Where they have an episode and then it's all like severe, and then they never get back to where they were before, and then it just grows and grows from there. For the acute phase, they're going to be inpatient in the hospital. These guys might not come for treatment because they enjoy the energy and they enjoy feeling happy and everything, so they might get brought in because of like another condition, or maybe like it's the legal problems or the substance abuse that ended up bringing them in, who knows. But they're going to need referrals to therapy, problem-solving training, and like we mentioned, lithium's #1 treatment. SSRIs can lead to mania or make more maniac. Lamotrigine is also used, may help with paranoia. The lithium competes with the sodium, so if you have hyponatremia, then you can have elevated levels of lithium. If you have hypernatremia, then you could have like lower levels of lithium. So you have to teach them. There's this one page in here. So there's this chart on page 230, which I think is a good one to know, like this one right here. I would look at that one. And then like the interventions, like how you would talk with them, I would pay attention to that one, because it looks like that's what we're studying. And then this one here, definitely pay attention to this one. And this one is on page 235. So like when it comes to talking with them, know about that, and then know about the medications as well. I think that's what we're focusing on. The communication aspects of it, and then the medications, and also like the nursing interventions that are needed. So if they're vomiting, that can lead to, they can have lower sodium, which can cause an increase in lithium, so you're going to need to like talk with the provider if they're vomiting stuff. Lithium is contraindicated in renal and thyroid disorder and disease. Let's see here. So you're going to want to make sure that you do your assessment, the vital signs, finger foods, 5-minute checks, or 15-minute checks. And then like you might have them do like a B52 to like get them to calm down, encourage rest. Distractions are a really good way of like dealing with bipolar patients. You like say like, come with me, or let's do this. If they're being disruptive, it's a really good way to handle it. Be non-judgmental as always. And then here are some medications probably want to pay attention to. I don't know if you can see that or not. Anyway, you have the anticonvulsants, and then like the benzodiazepines, like if they need to calm down or sleep. And then you might have some antipsychotics, like risperidone, if they're having a break. And then like those boxes like we mentioned, electroconvulsive therapy, if they're having mania like 3 to 4 times per year, like that rapid cycling, then that can electroconvulsive therapy can help. They may need to be in seclusion if they're not listening and harm to self or others, and if nothing else is working, and then you have to document it and do your assessment, and also make sure that you have a written order from the provider and everything. So you want them sleeping, eating, and like following rules. kind of as an outcome. So not so I'm going to cover with that one. And then there's this one table. We're going to anxiety disorder. So there's this table on 272. This table right here. You might want to look at that. It just talks about the different types of anxiety and how they would manifest, like in physical symptoms. Mild anxiety. That's the best time when you're gonna be doing the teaching. If it's moderate, then they have the tunnel vision, and they have this. That's what's like the selective inattention. They're just focusing on like what's important, and otherwise, they're like learning is not a good thing. With severe anxiety, that's when they're that you wouldn't want to teach them at that point, because they're like they can only like focus on like maybe like one thing, or like just like scattered details. They can maybe be like dazed. They can have somatic symptoms such as like headache, nausea, dizziness, insomnia. They can have like a pounding heart. So maybe like if you're like a mom and then your kid runs off in like Walmart and you can't find them, like you're gonna go from like mild where like I'm busy. And then like as you can't find them, then you'll just go up and up and up, and then eventually you might reach panic. So that's the most extreme, and you're unable to process like what's going on. Like maybe there's like people walking by and you don't even notice if they're there. Maybe someone's talking to you and you're not even picking up on that because all you can focus on is your kid and you're not even thinking straight anymore. So like you can have like pacing, running, shouting, screaming, like you're running through Walmart like looking for your kid, like where's your kid, and then they're like in like the clothing area like hiding, like hallucinations or false sensory perceptions, like seeing people or objects not really there. Maybe that happens. Autonomic behaviors are used to reduce and relieve anxiety, although such efforts may be ineffective. So I'm not exactly sure. Like maybe like running and shouting, So with severe, you're gonna have somatic complaints, chest discomfort, dizziness, nausea, sleeplessness, panic. You can't process what's going on, and you can have like numbness or tingling, short of breath, dizziness, chest pain, nausea, trembling, chills, overheating, stuff like that. So like just like think like Walmart, you're looking for your kid and then your kid's not around, so then what happens? Like that's when I think of like panic, that's what I always think of, because like I think I did that to my mom once, and oh boy. Anyway, so here's keep in mind that when evaluating whether the use of defensive mechanisms is adaptive or maladaptive, determine the most part their frequency, intensity, and duration of use. So those are 3 things that you're going to want to know about when you're looking at defense mechanisms. There's this really big chart over here. You might be good to go through some of these. This is on page 274. So there's different types of anxiety disorders. So separation anxiety, that's developmentally inappropriate levels related to being away from somebody. So like maybe like you have like someone and they're like 20 years old and they have to go to college, but they're acting like a 5-year-old when they have to go to their first day of school. It's just like very clingy and stuff. They can't function normally. Sleep disruptions, nightmares. They can be like they're like very clingy. They're very needy. It's just think of like it's like maybe like a mama's boy or like I don't know. I'm sure that there's people that you've probably run across, but it's just like very developmentally inappropriate. So like if it's like 5 years old, like if they're like like holding on to you and like crying or whatever, that's expected. But if it's like like 18 to 20 and it's the same thing, maybe you want to like consider that maybe they have separation anxiety disorder. And then the friend, spouse, or friend may become alienated due to the constant neediness and clinginess. Adults with this disorder often have extreme difficulties in romantic relationships and are more likely to be unmarried. Then we have specific phobias. Social anxiety disorder, also called social phobia, is characterized by severe anxiety or fear provoked by exposure to a social or performance situation that could be evaluated negatively by others. So, like, situations could be like fear of saying something that sounds foolish in public. So maybe like with like public speaking, we all have a little bit of this, you know. And then they, just trying to avoid it at all costs. So like maybe like like if you're going to like a concert, then you're always like freaking out because you're afraid that like somehow you're gonna like do some weird dance and everyone's gonna look at you and they're gonna stare at you and you're gonna be a moron and like you're gonna like all your friends are gonna drop you and you're gonna be kicked out because you're such a you're such an awkward, horrible dancer. Like maybe that's like a fear that kind of runs through their head. And that can cause a lot of emotional and anxiety because they're always afraid of like doing something wrong or screwing up. Small children with this disorder may be mute, nervous, and hide behind their parents. Of older children and adolescents may be paralyzed from hanging around with their peers. Fear of public speaking is the most common manifestation of social anxiety disorder. Let's see what we have here. I don't really have a whole lot of notes on that. And then we have panic disorder. Panic disorder, you have panic attacks, and panic attacks are the sudden onset of extreme apprehension or fear, usually associated with feelings of impending doom. So they like have all these physical symptoms, and then they think that they're going to die, or something like that. They may believe that they're losing their minds or having a heart attack. Typically, these things happen out of the blue. They are extremely intense, last a matter of minutes, and then subside. So they can be about 10 minutes. And then like this can be like really bad because they can happen unexpectedly, and then the person, they have such intense bad feelings about it, then they're like limiting where they want to go, what they want to do, because they don't want to have these like horrible feelings come again. And then it kind of like just, I think it's like a domino effect. It just or a snowballing effect. It just gets worse and worse because they have more panic, and then it happens. Yeah. So. And then there's generalized anxiety disorder. So they have like common worries, and generalized anxiety disorder are inadequacy in interpersonal relationships, job responsibilities, finances, and health of family members. They put a lot of time in preparing for activities. Putting things off and avoiding things are key symptoms. So like you're worried about something so much that you don't adequately prepare for it, and then something bad happens, and then it's just like it's like a self-fulfilling prophecy. So like if I'm worried about studying for an exam, then if I have this generalized anxiety disorder, I might just like forget about it and just like go out and like have fun and like go to a park or go to a movie or something. Just don't study about it because it gives me anxiety, and I'm afraid I'm going to fail because I don't think I can do it, because I don't think I'm that smart. And then lo and behold, the exam does come, and then I do horrible on it, and then I'm just like, I just suck at exams, and stuff. But it's the anxiety about it, and then they put it off, and they don't prepare for it, and then it's a problem. Even though, like, yeah. And family members and friends are overtaxed as a person with this disorder seeks continual reassurance, and it just goes on about meaningless details. So like they're always asking for reassurance, like, do you think I'm like that smart? Do you think I can actually do it? And then people eventually get worn out. Sleep disturbances are common because the individual worries about the day's events, real or imagined mistakes, reviews past problems, and anticipates future difficulties. And they can be fatigued as a result of that. So excessive anxiety and worry, apprehension, expectation occur more than not for at least 6 months about a number of events or activities such as school or work performance performance. So that's on page 277, that little box, DSM-5 criteria. Probably pay attention to that. Then they have substance induced anxiety disorder, and anxiety due to a medical condition. So, like, they can have like a pulmonary embolism, and then you can see that they're getting anxious, but there's a reason for it, because they feel like they can't breathe. You know, that's a legitimate reason, but and they have anxiety because of a medical reason. It's not that they have like they have anxiety for no reason. Substance induced anxiety disorder. They have anxiety, panic attacks, obsessions, or compulsions that develop with the use of a substance. So it could be like cocaine, heroin, hallucinogens, alcohol, that kind of thing. Like, one thing about like hallucinogens, there's like these mushrooms I've heard about, and like when people have them, they can have hallucinations, and it kind of depends on the person. Some people, it's like very euphoric and it's like, wonderful, and they have like this like higher level of like realization or something. And then other people, they get absolutely traumatized because they're like seeing like monsters the whole time. So that would be a substance induced anxiety disorder, at least for a while. So common causes of medical anxiety would be a pulmonary embolism, asthma, hypoxia, pulmonary edema. So anything that really like makes them feel like they can't breathe, that would be something that would cause that. And then we have obsessive compulsive disorder, so may involve issues of sexuality, violence, contamination, illness, or death. Pathological obsessions or compulsions cause marked distress on the individual, who would often feel humiliated and shame regarding these behaviors. So like maybe they just like imagine like there's like like salmonella everywhere in the kitchen. Like, you do some raw chicken, and then they just like think that there's like salmonella, and like they're gonna get it and it's gonna be awful, and they can just like imagine like all the dirty surfaces, and they have to wipe everything down with like soap and bleach and like clean it and stuff. But then and then they feel like safe, I took care of it, everything's fine and stuff. And then they're like sitting there, and then they're like, did I get everything? Like there's probably like some areas that I didn't like clean or something, and they're like thinking about it, and then they feel like they have to go and like clean everything, and like maybe clean the sink, get rid of the washcloth, maybe bleach the washcloth, something like that. And like maybe they like the person, they feel silly about this because they realize that like not like normal people don't do it. So they're like shamed and humiliated by it, but they're just like, they can't just like get out of it, like that. They can't get these thoughts out of their head, and they just like feel like they have to do it. And then once they do it, then they feel relaxed, but then it always comes back. Severe OCD occupies so much of the individual's mental processes that the performance of the cognitive task is impaired. So like they're so busy like with all these like ideas and compulsions and stuff that their life suffers because of it. Body dysmorphic disorders, so they don't see their body accurately. Patients with body dysmorphic disorder are commonly seen in community psychiatric cosmetic surgery and dermatological settings. Their preoccupation with imagined defective body parts results in obsessional thinking and compulsive behavior, such as mirror checking and camouflaging. People may be well aware that their thoughts are distorted, though. So, like, you can think about like some of the people in the news. Like, I think that there was this guy. He got plastic surgery to look like Justin Bieber, and he kept getting surgeries and surgeries and surgeries. And I don't know if I ever saw a picture of the real guy or not, but he didn't look very good in the end, and he had, I think it was like 2 or 3 of his ribs removed or something, and then I think he died of that. Anyhow, he had a whole bunch of surgeries, and he couldn't like smile or have any facial movements anymore, and he kept getting surgeries, and they were like, if you have all these surgeries, you're gonna die and stuff. But he kept having surgeries, and eventually he did die. So but there were just like always like imperfections and stuff, and he kept getting surgery to like improve it or look better, or that would be like body dysmorphic disorder that I would think of. And that's related to obsessive compulsive disorder a little bit. Or it's kind of like in the same family tree of disorders. Hoarding disorder. So they're purging what would have been extremely distressing. Okay, so basically they accumulate belongings that may have little or no value. Belongings literally fill every available surface and area in their residencies, and guests can or will no longer visit. And it can get to the point where it's unsafe and unsanitary. So, like, I think there was this TV show called Hoarders, and they would have these big houses, but they would have to have like a little pathway in between because they'd have like garbage and newspapers and everything all lined up. And let's see. And so this is a problem because it makes it more like an unlivable condition. They can accumulate junk and everything else and stuff. And yeah. And like, you know, like maybe they save like trash because maybe they think that they'll need it or something. I was in a psychology class, and let's see here. Anyway, there's like 10 top phobias you might want to go and study. That's on PowerPoints, and also like with anxiety, know that you might want to do like modeling or flooding to help with just like ease those specific anxieties. So like get them used to it little by little by little, like CBT or something, cognitive behavioral disorder. Just looking over my notes here. So yeah, with hoarding disorder, I actually heard that was related to like being traumatized and depression. Like for some older people, they were hoarders because they didn't like feel secure, and they just felt like they had to like get everything. I don't think that's in the book here. And then there's this thing called trichotillomania, and that's like they just pull all their hair out there, and it's related to obsessive compulsive disorder, and they just pull all their hair out. So, and the amount of hair ranges from small patches to complete baldness. And most individuals may be unaware of their behavior until they notice a wad of hair close by. The individual may engage, and then there's also this other, and then there's another one, skin picking of excoriation disorder. Except in this condition, they just like pick their skin as a means to deal with stress and anxiety, and they just keep picking and picking and stuff. Genetic variants have been identified that are associated with increased risk of anxiety and obsessive compulsive disorder. So they're saying that there's genetics involved. The amygdala plays a role. Norepinephrine, dopamine, serotonin, and GABA are involved. People with too little GABA may suffer from anxiety disorders. Benzodiazepines can help with that. Let's see here. So you're going to want to assess for triggers for like anxiety and obsessive compulsive disorders. They usually don't need to be hospitalized unless they're suicidal or have compulsions that would injure them, such as like, infecting sores from like skin picking or cutting themselves. And then you want a patient-centered assessment, and like you want to like really get a lot of the information from them about their illness since they're the expert. And then there's different like screening tools that you can use to like measure anxiety, like obsessive compulsive scales, hoarding scales, general anxiety disorder scales. If you're working with someone who has obsessive compulsive disorder, you can be frustrated or feel frustrated because it takes longer for them to go through all the rituals, and like as a nurse, they might seem like totally meaningless to us. So you just have to like kind of like take your time. The behavioral change is done slowly. And you have to do everything in slow attainable steps. You can't expect them to just stop cold turkey, because that would probably cause like a rush of like anxiety and discomfort for them. And then serotonin reuptake inhibitors. I believe those are the #1 drug of choice that we're going to be using. Yeah, so you have antidepressant, anti-anxiety drugs. So SSRIs are considered the first-line defense in most anxiety and obsessive-compulsive related disorders. And then for me, one little tip that I like to use is if it ends in a TINE and it's related to mental health, then I think that it's a selective serotonin reuptake inhibitor. I mean, there's some that end in pram and like other ones, but usually like I can like use the process of elimination and get pretty close. And then if it's mental related, then I usually just like go with that being a SSRI. So benzodiazepines are most commonly used because they have a quick onset of action. However, due to the potential for dependency, these medications should be used only for short periods until other medications or treatments reduce the symptoms. So like if like an SSRI might be really like a good choice, but it can take a while to kick in. So until that works, you might maybe have them on like lorazepam or something possibly. Beta blockers can be used to like slow down the heart if it's beating really fast. So there's a table 1511 on page 287. You might want to look through that and just be familiar with some of the different like I will look at this and be familiar with just some of the different medication names. And then there's also box 15.2 on page 288, and that just talks about like different medications, like teaching about medications and stuff. And then we have behavioral therapy, so that's on page 290. So you're going to want to look at modeling, desensitization, flooding, response prevention, thought stopping. Just kind of like over all that and make sure that the terms are familiar in case we get something like that. Somatic symptom disorders, there's 8 questions on that. Eating and feeding disorders, I think that's like 9 questions. And personality disorders, that is 8 questions. So I feel like the somatic disorders are relatively easy to go through. Let's just see what my PowerPoints. Whichever ones I have more notes on, I'll do that one. Those ones. So yeah, we'll do eating and feeding disorders, I guess. So one thing to like keep in mind with like bulimia nervosa and anorexia nervosa is refeeding syndrome, and this is when they're extremely malnourished, and like when they have like fluid imbalance abnormalities and abnormal glucose metabolism, hypophosphatemia, and they have low magnesium and low potassium and thiamine deficiency. So they have all these imbalances, and then when you try to like hydrate them and get them better nutrients and stuff, then their body, because it's so malnourished, they can have like a adverse reaction to it. So whenever you're like doing nutrition or hydrating them, even though they might really need a lot of the nutrition and fluids, you're always going to want to do like really, really slow, because you don't want to shock their body, because their body is just so malnourished, it's not used to it. So when you reintroduce it back into their system, it can really shock them. So always do it slow. So with eating disorders, they do not seek help, and it's hard to know the true numbers of the people with eating disorders. Are because the culture has like a focus on skinny women. It's like, if like everyone, like when you're talking about losing weight or you see someone getting skinny, it's always like, we always think it's like kind of like a good thing. So maybe it's probably not. I don't know. So some of the dangers: you have anemia, weakness, cardiac arrest, electrolyte imbalances, lango, fine downy hair, low blood pressure, and peripheral edema. That's some stuff that you can find. You're going to want to assess their you're going to want to assess the way that they perceive themselves. You're going to want to assess like how they view their body. They're obsessed about food, and they can be like embarrassed about that, like, you know, like always like trying to like have like the lowest calories, or trying to like really watch what they eat, and they can be embarrassed by that. You want outcome with 90% of ideal body weight according to height. Family members should be involved. You need to do a self-assessment. Males are affected too. A lot of people can be suffering in silence. Wait to give SSRI until at ideal body weight. And the development of the disease is rarely about the food. It's usually about there's like another like reason why they develop the eating disorder. Excuse me. And it's important for them to understand like the cause of why they developed this disorder. Like, was it because they felt like they weren't important, or like no one would care about them and stuff? Like, what's the big problem there? You're gonna observe them after meals. Meals are set. Need to feel in control of some. Okay, so when it comes to like food in the treatment setting, everything is very like strict. You don't give them a lot of control over one way or another, because they're always gonna try like reduce how much food they take. Vomit afterwards kind of deal. So you're gonna set very firm like limits and boundaries regarding like meals and stuff, but they still have to feel in control of something. So like you can have them do like you can have them like sign contracts about like their treatment, you know, and that can help. If they feel more in control of like some things, then they're going to be more successful than if you take all the control away from them. So you can do individual therapy, group therapy, family therapy. You're going to get the family involved. If the kid's involved with an eating disorder, then you're going to want to work with the parents. They have low self-esteem, poor interpersonal relationships. But they need to be medically stable first before you can actually like work on the underlying treatment of the disorder. And you're going to want to do it slow so they don't have refeeding syndrome. You're going to want to interrupt the cycle of obsession. They need to learn to accept themselves. Monitor meal times, alter after, and group therapy is really good to do after meal times. So it's related to an emotional problem. So yeah, binge eating is like an emotional problem. Like they like comfort eat, you know, they have a problem, so then they're just like comfort eating. They have like too much food intake. Include behavioral weight loss program. SSRIs may help if high enough dose. And TCA if benefits. So, and that's that one on my notes. And then I think that for the somatic disorders, it's pretty self-explanatory, I guess. I have a lot more notes on personality disorders, so I'm just going to focus on personality disorders right now. So personality disorders are very common. They can be from mild to extreme. They're very, very hard to treat because it's related to the personality, and like once a personality is developed, you can't really change it all that well. And also, a lot of them have an inability to recognize that they have a problem. I think there's like some special name for that. So probably want to be familiar with the term. Personality is an individual's characteristic pattern of relatively permanent thoughts, feelings, and behaviors that define his or her quality of experiences and relationships. So personality disorders are among the most challenging and complex group of disorders to treat. Individuals who meet criteria for these disorders display significant challenges in self-identity or self-direction, and they have problems with empathy or intimacy within their relationships. People with these disorders have difficulty recognizing or owning their difficulties, and owning that their difficulties are problems of their personality. So, like, you can think of, like, maybe, like, someone with, like, avoidant, or maybe, like, someone that's a narcissist. Like, no one wants to be around them, but, it seems like they don't really, there's, problems there. So, like, half is from the environment, like the factors for developing, like half is from the environment. Childhood neglect or trauma has been established as a risk factor for personality disorders. So here we go. Personality disorder. So we have paranoid personality disorder is characterized by long-standing distrust and suspiciousness of others based on the belief, which is unsupported by evidence, that others want to exploit, harm, or deceive the person. These people are hypervigilant, anticipate hostility, and may provoke hostile responses by initiating a counterattack. So anytime you have like a paranoid person that has like a delusion or something, you kind of want to like pay attention to it, because if they're like really delusional and they're like really like believing in that, then they might attack somebody just because they anticipate being attacked first. Young people with this disorder are frequently teased due to their odd behavior. Projection is a dominant defense mechanism whereby people attribute their own unacknowledged feelings to others. So like maybe they say like, like those people, they never hang out with me, they don't like me or whatever, but maybe it's because they don't hang out with people and they don't like them or something, it's like whatever they're feeling, they project onto other people and say that's other people. So guidelines for nursing care, considering the degree of mistrust, promises, appointments, and schedules should be strictly adhered to. So like anything different, they're gonna assume like for like paranoid. So if like you're agreeing that they have an appointment on this time, or you're gonna go visit them on this time, like maybe, I don't know, and you don't show up on time, then maybe they think that you called the cops, or you turned them in, or you did something, or you're scheming, or you're gonna rob them, or you're gonna kill them, something. It's like if it's not done exactly as planned, then it means that you're up to something wrong, or there's like something wrong going on. And also, like, if you're too nice or too friendly, like, hey, how's it going and stuff, then they're gonna be like, what do you want from me? What's going on here? They don't trust. Use simple language and project a neutral but kind affect. So like, you don't want to seem like you have anything going on your end. You want to give them like as neutral as possible, so that they don't think that there's an underlying thing going on. Limits setting is essential when threatening behaviors are present. They tend to reject treatment. If somehow they end up in a psychiatric treatment setting, they may appear puzzled and obviously suspicious about why this is happening. They are difficult to interview because they are reluctant to share information about themselves for fear that the information will be used against them. Psychotherapy is a first-line treatment. Group therapy is threatening to people with paranoid personality disorder. Although it can be useful in improving social skills. So there is like some anxiety medication that they can be given. They also don't think that there's a problem. So, and then we have a schizoid personality disorder. They exhibit a lifelong pattern of social withdrawal. They are somewhat expressionless and operate with a restricted range of emotional expression. Others tend to view them as odd or eccentric due to their discomfort with social interaction. There's an increased prevalence in families with a history of schizophrenia or schizotypical personality disorder. They do not seek out or enjoy close relationships. Neither approval or rejection seems to do much matter much to them. Friendships, dating, and sexual experiences are rare. If trust is established, the person may divulge numerous imaginary friends and fantasies. Individuals with this disorder may be able to function well in a solitary occupation, such as security guard on a night shift. They are often endorse feelings of being an observer rather than a participant in life. So, like, if they do ever group therapy, then they can just, like, watch, and they might not talk or engage much, and that's normal for them. And you don't want to be too nice or friendly with them, and you don't want to really increase socialization. It's just not in their nature to be social. So, don't really want to force it too much. So, Wellbutrin, Wellbutrin may help increase pleasure in life. That medication is listed on page 455. Let's see what else I got here. So the loners, observers, antidepressants, antipsychotics might help. And they were likely raised in a neglectful home. And then the other one is schizotypical personality disorder. They have severe social impairments, may be involved in cults or religious groups, no break with reality. You can reason with them. With schizophrenia, you can't. You're going to give antipsychotics. Don't push into group therapy. With the schizoid personality and the schizotypal personality disorder, you don't want them to get bullied by other people. So let's see what else. Schizotypal is more common in men than women. They likely have relatives with schizophrenia. Severe social and interpersonal deficits. They experience extreme anxiety in social situations, which is why you don't want to push them into group therapy. Contributions in conversation tend to ramble with lengthy, unclear, overly detailed, and abstract content. They can be paranoid. They can be overly suspicious and anxious. The major difference between this disorder and schizophrenia is that people with schizotypal personality disorder can be made aware of their suspicions, magical thinking, and odd beliefs. So, you can reason with them. So you're going to want to respect their need for social isolation, perform careful assessments, be aware of strange beliefs and activities. And then, like with any of the mental disorders, you're going to always want to assess for suicide. Like any hint of hopelessness or self-harm or anything, always assess okay, do you feel like hurting yourself? And if it's yes, then always ask do they have the means to do it? Then we have the histrionic personality disorder. I don't know. The histrionic, I just think hysteric. Personality disorder. So they are excitable and dramatic, yet are often high functioning. So they may be considered the drama queen, drama major. They are very extroverted or flamboyancy, colorful personalities. They tend to have a limited ability to develop meaningful relationships. They are very attention-seeking. Self-centered, low frustration tolerance, and excessive emotionality. Relationships do not last because the partner often feels smothered or reacts to the intensity of the person. So, like, you tell them that your uncle died of a brain tumor, and then they tell you that they have headaches, and they might have a brain tumor. They do not think that they need psychiatric help. Antidepressants, if depressed, consistent and professional. That's how you want to be towards them. Clarify their own feelings. Assess for suicide. Death by suicide is usually an accident. It's usually like, I'm going to kill myself, and then they're going to try to get attention. And then if they died by suicide, it was an accident because people didn't get their own time or something. So, understand that seductive behavior is a response to distress. Keep communication interactions personal. Teach and role model assertiveness. And like instead of like doing all these like attention seeking things, you're gonna want them to like focus more on their like feelings and clarifying their feelings and stuff like that. Then we have a narcissistic personality disorder characterized by feelings of entitlement, exaggerated self-belief in one's own importance, a lack of empathy. They actually suffer from a weak self-esteem and hypersensitivity to criticism. So they seem like all arrogant and like pushy and like they don't care or whatever, but they're really sensitive, and being a narcissist is kind of like a mask or a way to protect themselves. More common in males and females. Let's see. Relationships are poor, very low self-esteem. Fear of abandonment is the heart of it. Neglected or criticized growing up. So cognitive behavioral therapy can be treatment. Group therapy, you want them in group therapy so they learn empathy. But when they're in group therapy, you're going to have tight control. No power struggles. Be matter of fact. Fear of abandonment is often the motive. You don't want to become defensive in response to the patient's disparaging remarks. Role model empathy. And then we have avoidant personality disorder, are extremely sensitive to rejection, fear inadequate, and socially inhibited. They avoid interpersonal contact due to fear of rejection or criticism. The main traits are low self-esteem associated with functioning in social situations. They feel inferior. They are especially sensitive to and preoccupied with rejection, humiliation, and failure. And they avoid relationships or activities due to the fear of criticism or disapproval. So nurses should be friendly, accepting, reassuring approach. Remember that being pushed into social situations can cause severe anxiety for these people. Convey an attitude of acceptance towards patient fears. Provide the patient exercises to enhance new social skills, but use with caution because any failure can increase the feelings of poor self-worth. Assertive training can assist the person to learn to express needs. And like there was like one of these where you don't want a narcissist to either be with an avoidant or with a dependent. I think you don't want a narcissist and a dependent to be friends or team up because it's not going to work out for them, because they're both going to sit into those roles and they're going to reinforce each other, and then they're never going to get the treatment that they need because they're always reinforcing each other. Dependent personality disorder characterized by a pattern of submissive and clinging behavior related to overwhelming need to be cared for. This results in intense fears of separation. Dependent personality disorder may be the result of chronic physical illness or punishment for independent behavior as a childhood, so learned helplessness, essentially. People with dependent personality disorder have a high need to be taken care of. Because they lack confidence in their own ability or judgment, they may manipulate others to assume responsibility for such activities such as finances or child rearing. So oh, I'm not so sure I can do this, or what would you like check? And then the person just takes full control over it. Nurses can help the patient identify and address current stressors. Be aware that strong countertransference may develop because of the patient's demands for extra time and crisis states. The therapeutic nurse-patient relationship can provide a testing ground for increased assertiveness through role modeling and teaching of assertive skills. So assertive training, really something you want to try to promote. There are no specific medications indicated for this disorder, but symptoms of depression and anxiety may be treated with antidepressants, anti-anxiety medications. And then we have the obsessive compulsive personality disorder, characterized by limited emotional expression, stubbornness, perseverance, and indecisiveness. They're preoccupied with orderliness, perfectionism, and control. The main pathological personality traits are rigidity and inflexible standards of self and others. They persist in goal-seeking long after it is necessary, even if it is self-defeating or relationship-defeating. So, and also like with avoidant personality disorder, you can help with the SSRIs too. And then, yeah, so very rigid and flexible. So like they think this stems from excessive parental criticism, can have anxiety and depression. You don't want to power struggle with them, but you do want to give them some control. Unexpected changes are bad for them, and they need structure. People with obsessive-compulsive personality disorder often do feel a genuine affection for friends and family, yet leisure activities and friendships are dropped in favor of obsessive devotion to work and productivity. So, alright, so you don't want power struggles, provide structure, and assist with identifying ineffective coping mechanisms, and you want them to develop good coping. And then there's antisocial personality disorder. They're deceitful, manipulative, for personal gain, or hostile if needs are blocked. High risk taking, disregard for responsibility, and impulsivity. Criminal misconduct and substance misuse are common in this population, and if they're getting treatment, it's because like the court ordered or something like that. They were forced to. Profound lack of empathy, also known as callousness. The individual may exhibit a shallow, unexpressive, and superficial affect. They may also be adept to portraying themselves as concerned and caring if the attributes help them to manipulate and exploit others. A person with antisocial personality disorder may be able to act witty and charming and good at flattery and manipulating the emotions of others. So that's kind of like how Gail was saying, like you like talk with them and they're all fine. They're like, oh, you know, they shouldn't be here. They're fine, you know. Yeah. Inconsistent parenting, discipline, significant abuse, and extreme neglect are associated with this disorder. So that's all I have. There is borderline personality disorder, and that is on page, where is that? That's on page 462. Let's see, what do I have on borderline personality disorder? Severe impairments, emotionally liable. It's out of proportion. They're very impulsive, poor relationship, self-destructive, high suicide rate. You can have anxiety and depression, self-hate and loathing, strong genetic links. So, aggressive behavior, suicide attempts, always assess suicide, may threaten suicide, then die, need frequent staff meetings, set limits, fact of matter, don't discuss like, you don't want to, like, discuss things an awful lot with them. You just want to, like, give it to them, like, how it is. Do cognitive behavioral therapy, group therapy, learn to socialize, learn coping skills, and they do splitting. Or splitting is a characteristic. And then one more thing about antisocial personality disorder. If you can intervene when they're a teenager, that can help. There's really not much you can do with them. A cognitive behavioral therapy isn't much success. They're just kind of how it is. So, and that's kind of it. I hope my notes kind of helped. Hopefully on Thursday I can start working on med-surg, and then that'll actually be better. So hopefully it helped at all. Thanks. Bye.